So we're going to talk about cardiovascular health and being heart healthy, an important topic for us as Americans because it's the most common reason for death. So heart disease, it's the leading cause of death in the United States for men and for women. And this is important because a lot of women think that heart disease is just a man thing, kind of like colon cancer. A lot of women don't think they need colonoscopies, and really both affect almost equally. In fact, women have rapidly caught up with men in the rates of death from heart disease in the last 15 years, and we're almost neck and neck. It claims more lives than all cancers involved. And so you think about how much we worry about getting cancer. Heart disease trumps that by a large amount. This year alone, 735,000 Americans will have a heart attack, all right? For 525,000 of those people, this will be their first event. They will never have had a heart attack, all right? And we're going to talk about in this, how we can avoid those things and some of the ways that in our clinic we try to find that cardiovascular disease before it happens, because that's really the goal. So warning signs, we all know, the crushing chest pain. It's more than just chest pain. I also tell people, any pain that extends up into the neck, down into the arm. The classic is left-sided that goes down into the arm, but women have very atypical signs. They can have pain in their back. They can have jaw pain. They might have nausea and just sweat profusely. So, I think that's one reason that women are catching up faster is we're probably not as good at recognizing when a woman is having a heart attack. They're more likely to die from their first heart attack than men are. And so early recognition is important. So shortness of breath is one of the warning signs. And then I mentioned the nausea, lightheadedness, and cold sweats. So what are the risk factors? We're all taught that cholesterol is the biggest risk factor. But the truth is that there are other big risk factors are not just cholesterol, but smoking, high blood pressure. About 50% of people that have heart attacks have one or more of those three risk factors. Other major risk factors are diabetes. Diabetes actually is what we call a coronary artery equivalent, or a coronary disease equivalent, meaning that if you have diabetes, your risk of having a heart attack is the same as someone who has already had a heart attack. So we treat those patients as if they've already had a heart attack. We're aggressive at lowering their cholesterol. We're more aggressive with their blood pressure, more aggressive with diet, with our diabetic patients. Being overweight, being physically inactive, having a poor diet, and then excessive alcohol use. 15% of non-smokers with normal cholesterol and normal blood pressure and no family history of cardiovascular disease still have heart attacks. So this is the population we're really worried about. How do we find out who these people are? They don't fit into that normal paradigm of the overweight smoker who's had high cholesterol. So some of the risk factors are non-modifiable. Obviously, well, for the most part. I guess this one is technically modifiable, but not from a genetic standpoint. Advanced age is one. As we get older, our risk does go up. Being a male is for the most part, non-modifiable risk factor. Having relatives with coronary heart disease. I tell patients all the time, you got to do a better job at picking your parents. They really do set us up for a lot of problems. And then genetic abnormalities. There is this familial hypercholesterolemia. And so when I have family members who've had heart attacks, I check their kids at a pretty young age. I mean, we've checked 12 and 13-year-olds in here and found some pretty alarming abnormalities on their cholesterol tests. So what are some of the modifiable risk factors? This is probably the risk factor we try to modify the most. So diabetes or impaired glucose tolerance. I like to call diabetes diabesity, and we do know how to fix diabetes. It's through diet and lifestyle modification. The lipid problems, so unhealthy cholesterols and unhealthy blood levels of certain proteins that carry those cholesterols. And then a high concentration of the LDL or bad cholesterol. And we'll go into more detail about what those cholesterols are. Obviously low good cholesterol, You can look at LDL to HDL ratios, and really that's more of a scorecard, who's winning, your good cholesterol or your bad cholesterol. Tobacco smoking increases your risk by 200%. And there's a recent study that it said vaping, which is kind of the new thing, may actually increase your risk for heart disease even more. So there's something in the vapor juice that when it's oxidized, it's actually more inflammatory than tobacco. So that's something I think we have to watch pretty closely because it's becoming more popular. In fact, a lot of people who never smoked before are choosing to vape, which is, I think, kind of an interesting thing. Elevated C-reactive protein is a modifiable risk factor. We'll talk more about that later. B vitamin deficiency, especially B6, having a low thyroid, so hypothyroidism, and then obviously obesity, which I think we would probably call this person obese. This is, by the way, a good example of what a butt-to-gut ratio is. If your butt is smaller than your gut, that's an improper butt-to-gut ratio. And that's actually predictive for cardiovascular disease on its own. It's actually an independent risk factor. So some of the emerging risk factors that we look at in our clinic is we look for hypercoagulability. This is actually a genetic test that you can do to see if you have a hypercoagulable state. And if you do, we kind of modify the risk by using some medication for that. Postmenopausal estrogen deficiency. So as you age, as women age, the estrogen decreases, and that's actually a risk factor for cardiovascular disease. A high intake of saturated fat. This is probably one that will change a little bit. We're finding out that certain saturated fats in the diet aren't as bad as other saturated fats. So when you are going to take in a saturated fat, I think finding saturated fat from lean animals, those that are grass-fed, tends to be less inflammatory than the saturated fat from animals that are stressed and not living probably the way they need to be. Trans fats is a huge one, and for the most part trans fats are illegal, but you'll still find them. Even though it says 0 trans fat on the label, the food companies can have a certain percentage of trans fats, and as long as they stay under this number, they can put 0 on the label. So anytime you see a partially hydrogenated oil, just memorize that that equals trans fat, and that's probably the most inflammatory fat that you could take in. So things like, I can't believe it's butter, I can't believe people eat it. Don't, just stay away from that stuff. Margarine, it's terrible. Those are all partially hydrogenated. You ever wonder why they put beta-carotene into margarine? Have you ever looked on the ingredients? There's always beta-carotene on the tub of margarine. Margarine, when it comes out of whatever machine that does the hydrogenation, is gray. It looks like silly putty. It's really, I mean, you would not spread this stuff on your toast. So the beta-carotene gives it that buttery, I can't believe it's butter color. So watch for trans fats, really read labels closely. A high carbohydrate intake, and this is something that we're doing in our lifestyle program. Those participants, some of you are here tonight, we're really focusing on this particular risk factor because it's one that that really, it kind of echoes in a lot of areas of cardiovascular disease. So we really work on decreasing carbohydrate intake. Having elevated levels of triglycerides, and that also goes along with carbohydrate intake. Elevated levels of homocysteine, uric acid. We look at serum fibrinogen. LP little a is another kind of genetic risk factor that's emerging. And then chronic inflammation. And this is a lot of people aren't really checking inflammatory markers. But in our lifestyle program participants, we've checked inflammatory markers across the board in everybody. And it's been impressive to see how many have had significant elevations. So we're working on decreasing that, as well as insulin levels. And then we talked about how, last month, how interrupted sleep and sleep dysfunction, like sleep apnea, can lead to increase in heart disease. Certain bacterial infections can also create and do that, and then air pollution. So if you live in Shanghai, you're in trouble. And there are days in Shanghai when you can't see to the 3rd story of a building because the pollution is so bad. So how do we do this? Well, there's serum testing. And the classic serum test is just your total cholesterol, your LDL, triglycerides, and HDL. And this is what, when your company sends you for a wellness exam, this is primarily what you're getting. That along with blood pressure and a BMI. BMI is body mass index. It's basically a measurement of your height and weight, and it's put onto a chart. But I had a guy come in today, his body mass index was 39. He has about 10% body fat. His chest is twice as big as mine. And by the standard of BMI, he would be considered obese, right? But he's not. And so a lot of what I think we're measuring is not accurate. It's not giving us an accurate picture of what's going on the inside. And I would say this is a good example, and we'll kind of show why. So in our advanced testing, we measure those above. And by the way, LDL, most people, when they get an LDL checked, it's not a direct measurement of LDL. They're actually calculating it or guessing. And they do it by an equation. So very few labs will actually measure LDL. And if your triglycerides are too high, they won't be able to tell you what your LDL is. So we see that a lot. So in advanced testing, we do a direct measurement of all of those. Plus, we look at apolipoproteins, lipoprotein particles, those inflammatory markers that I mentioned, genetic markers. We actually measure omega-3 levels, so we can tell whether people are getting enough of the cold water fatty fish in their diet. And then some enzyme levels like CoQ10, and actually quite a bit more. So that's a form, serum testing. I say it's a form of non-invasive testing. I guess putting a needle in your vein is invasive somewhat, but then there is truly non-invasive testing. So this is an example of carotid intimal thickness. And so you can see this is normal carotid intima. So the carotid is the artery in the neck. It's one of the major arteries that feeds the brain its blood supply. The reason we check that artery, it's really close to the skin, and it's easy with an ultrasound probe to scan it. And so we can measure the thickness, and we get a pretty good idea of whether there's plaque. If there's plaque here, there's going to be plaque in other places. And so you can see this person, in this part of their intima, they have a plaque that's forming. And so we can actually measure that plaque and get a good idea of what that person's risk is over time. And then by making dietary changes and lifestyle changes, we can go back in a year and remeasure it. And hopefully that plaque, we can get that plaque to shrink. So this is some testing that we're going to be offering about 2 months from now, is the carotid intimal testing. There's EKG treadmill. So this is actually looking at an electrical testing of your heart. A treadmill is where we put you, we actually stress you. So a stress test. They run you while you're being traced electrically. And that's a good functional test to tell us whether there's some changes in blood flow to the muscle as you're exercising. Echocardiography is using an ultrasound to measure valves, to measure chambers, to measure function of blood flow as it comes in and out. It can find heart failure and some other things. These are all, like I said, non-invasive. Coronary calcium score is done with a CAT scan. And so they actually take a CT scanner, and it's got special software, and it can calculate how much calcium is in the heart. The idea is that as these plaques, the longer these plaques are around, they become calcified and stiff. And so the more calcium we have in there, you can actually measure that and give somebody kind of an extrapolation of how much stiffness they have in those arteries. And then heart rate variability, I think, is kind of an interesting one. This is one that you can test at home. There's an app from a company called HeartMath, and they've actually looked at the variability from beat to beat. When we have a high amount of variability from beat to beat, that's a sign of physiologic relaxation. When our variability decreases, meaning we're more like a metronome, that's a very stressful pattern, and that is predictive of cardiovascular disease. People can train themselves through biofeedback to decrease their amount of cardiovascular stress by using that HeartMath software. It used to be really expensive, but now they've got a device that clips under your ear and plugs into the bottom of an iPhone. I mean, an iPhone is basically an $850 computer, and so the software runs on the iPhone now, and it's really pretty slick. So HeartMath is the name of that company. So invasive testing, this is what we're all about here in Wichita. We do more heart caths in Wichita per capita than anywhere else in the world, I've heard. Now that was from 10 years ago, so I don't know if that's changed, but we do quite a bit of catheterization. So in this procedure, they actually make a little incision down in the groin and insert a catheter, and they take that catheter all the way up to the heart, and then they inject dye. So this is a fluoroscope of the arteries of the heart. And so we can see the left anterior descending artery. This is what has been called the widowmaker. because when that one blocks, that's usually it. There's no more to be done. There's a narrowing here that you can see, but there's good flow past that. I had a patient last Friday, a young guy actually, 40, who had chest pain, came into the clinic, and we didn't really know what was causing it, but we ended up sending him to the hospital to get some further evaluation done. And then later that night, as they were admitting him for observation, later that night, he clotted this one off at 100%. And so they had him in the cath lab. They were able to put a stent in there, open it up, and he had instant pain relief. Had he been at home, I don't know that it would have worked out that well for him. So he was very fortunate.
Had a good doc.
Well, I think the doc was lucky that night. So that's coronary angiography, possible stenting is what they do. They can also do ultrasounds from inside the heart to see much more detail of those carotid arteries than you can see from the outside. They can also do electrophysiology studies. Jolene's husband has had that done before. And they can do carotid angiography, which is looking at that carotid artery. So those are all the invasive ways. So let's talk a little bit more about cholesterol. When we've talked about those standard tests, really what we're measuring is just the tip of the iceberg. And if you've seen the movie The Titanic, you know that the tip of the iceberg isn't really what you have to worry about. It's what's underneath the water. And so with our advanced lipid testing, we really feel like we can measure some of these markers that are a little bit tell a better story of what's going on. You know, what do we need to do with the person to prevent cardiovascular disease? So you can see those are a lot of the things that we measure. So total cholesterol is just a calculation. It's your LDL cholesterol plus your HDL cholesterol plus the triglycerides divided by 5. I'm missing a plus sign in there. LDL is what we've historically called bad cholesterol. There actually is good LDL. So we look to see what does your LDL look like, and is it the bad type or is it the good type? There's HDL, which is your high density lipid, and this tends to be the cholesterol that's more beneficial. It can actually go and help clean up the arteries a little bit. And then we have triglycerides. And triglycerides are an amazing storage vehicle of energy. They store the triglyceride molecule, and we create triglycerides in the liver as a response to carbohydrate intake. And so a lot of people that have really high triglycerides, it's because they're taking in way too many carbohydrates. Then there's a new measurement that's been put on most labs, and if you've had a cholesterol test in the last 3 or 4 years, you should have this one on your paper. It'll say non-HDL, and non-HDL is really the sum of all the bad cholesterol. And there's a lot of things in that non-HDL that aren't measured but implied. So the VLDL, which is a very low density lipid molecule, Lp(a), which we'll talk about a little bit later, the intermediate density lipids, and then the small dense LDL, which is probably the most dangerous LDL, is that small dense one. So when we talk about the LDL particles, LDL-P is very different from LDL. And so we want to directly measure those LDL particles. And those particles are actually the carrier of LDL cholesterol. So think of the LDL particle as being a car that's carrying things like triglyceride and LDL. So this is a good example. I like to show this chart because both of these patients have the same LDL cholesterol level, but very different LDL particle numbers. And so which highway would be the more congested one? And obviously it'd be the one that has the higher number of LDL particles. And the other thing that I like to say is that the cars can get into really tight places that buses can't get into. So this is another reason why having a high LDL particle leads to that formation of a clot inside the lining of your arteries, because these little particles can slide through. You really want your highway to be full of buses. And so a low LDL particle number with a high LDL, we wouldn't really worry about that much. That's probably a good pattern. So let's talk about the small and dense LDL. We talked about, well, there's good and bad LDL. The small dense is definitely the bad LDL. It's more atherogenic, meaning it can get into the wall of the artery and create that little bump that eventually ruptures and turns into a plaque. Like my patient last Friday night, he probably had a little atheroma formed, and then because of inflammation in a perfect storm, that thing ruptured and immediately clotted off. The large buoyant LDL particles probably represent our dietary fat intake. And what we've learned in this latest recommendation is that dietary fat's not bad. We don't need to worry about dietary cholesterol for the most part. The small dense LDL is 3 times more likely to cause heart disease than LDL itself. And yet this is a measurement that most people aren't getting on their standard cholesterol panel. So this is a great example of how that large HDL is like a big beach ball. It's just bouncing through. It's not going to get into these little gaps that we call the calveoli. But the small dense LDL particles that are in those, when your LDL particle size is really high, that means you have the really, really tiny particles that are going to get in there and cause some problems. So we'd rather change that to the large LDL particle. And we'll talk about, right after Heather gives her presentation, we'll talk about some dietary things you can do. So HDL particles, again, these are the vehicles that carry the good cholesterol around. And so I like to think of these as big garbage trucks. And the more garbage trucks you have going around your neighborhood, usually the cleaner the streets are going to be. You're not going to have big piles of garbage everywhere. And so we want more of the HDL cholesterol. So there's an example of an HDL-2 particle that is holding a lot of HDL and actually going and cleaning up the bad LDL, bringing it back to the liver. HDL-2 can actually get inside those plaques and can actually reduce that. So that's where we see that carotid intima thickness decrease over time. So we can fix those plaques by increasing the amount of HDL-2 that we have in the body. These are your little HDL shovelers. I like visual images because when you look at your test, you can kind of get an idea. Oh yeah, those are little guys that are cleaning up my arteries. I like to have more of those little guys. Just seeing the word HDL doesn't really impart what it does. So ApoB. This is another lipoprotein that we measure. ApoB is a protein cap that's on top of an LDL particle. And what it does is it actually acts as a key that sort of unlocks the gap and allows it to get into inside the artery, the wall of the artery. And so you can see these are the little ApoB caps that just slide that right through. So again, ApoB is a bad protein to have on your LDL particles. You don't want those. So ApoA1, the way it works is it's really a good apolipoprotein. And it sort of supercharges the HDL molecule by allowing it to be more efficient in removing those plaques and removing that LDL that's been captured inside the intima or in the artery itself. So more ApoA1, less ApoB. LP(a), this is a particle that's near and dear to my heart because I have it. And this is the most deadly molecule that we have. And it's predominantly determined by our genetics. So I got this from my parents. I'm fortunate though, I don't have any really heart disease in my family, but I'm still working very hard to get this particular particle down. So it's got a little corkscrew on it, and that's really probably what allows it to really get in, and it makes it much more difficult for your body to remove. And it builds up over time. So the longer you're alive, the more LP(a) it can be dangerous for you. Again, it's an inherited trait. It doesn't really respond to diet and exercise. However, if your ApoB is very low, and again, the ApoB cap, if the cap isn't there, then the LP(a) may not be able to get into that lining of the artery. So I'm working a little bit to try to get LP(a) down, and niacin does help, but I'm really working to get the ApoB down as well, because that's really, I think, how we're going to decrease that. So niacin 2 grams a day can help. But it can't be the no-flush niacin. No-flush niacin is also no-work niacin. So some inflammatory markers that we measure. C-reactive protein. This is found in higher levels in people who have adipose tissue or who are heavier. It's an inflammatory marker that also goes up when you have a cold. So it's not a very specific marker. Arthritis can increase it. Gingivitis can increase it. But even gingivitis is considered a risk factor for heart disease because of that inflammation. Fibrinogen is a sticky protein, so if I came up and punched you in the arm and measured your fibrinogen over the next day, it would increase because I've created some vascular damage and fibrinogen's going in there and sealing up the tiny little holes in the vessel. However, it's also an inflammatory marker, and if it's elevated when there is no sign of injury going on right now, that's kind of a worrisome sign that we also try to follow. So, Lp(PLA2) is a newer inflammatory marker that we've just started measuring probably in the last 9 months, and this is specific to coronary arteries. So whereas CRP is non-specific, it's just inflammation over the whole body. The Lp(PLA2) is specific to inflammation in your arteries. And then myeloperoxidase, this is one that the Cleveland Clinic has been measuring for probably 10 or 15 years. And it's, as those LDL particles get stuck in the inside wall of our arteries, macrophages, which are cells from our immune system, they're like big Pac-Man guys. They come in and they'll try to clean away some of that stuff. But when they do, they sort of activate the immune system and they activate inflammation. So they're really probably more of a problem than they are a solution. Myeloperoxidase is the enzyme that's released by those macrophages. So when we see that's high, that really makes us think there may be some plaquing going on. We need to probably be more aggressive or maybe remeasure in a shorter period of time. Okay, so lifestyle recommendations, otherwise known as how do we fix this stuff without drugs? So I'm gonna let Heather come in and talk about that. All right, well, so all the people that decided to stay home and watch on YouTube just missed out on that amazing stuff that Heather showed. So, so we really do, it's not that we're against using medications, but like I said at the beginning of the lecture, you know, in the 1950s, I think we just really pinned all of our hopes on being able to fix every problem with a pill. And so our first step is to look at how we can modify lifestyle. And so with lifestyle, it really does come down to diet. So like Heather was saying, you know, decreasing our intake of refined carbohydrates and starches. This is, if you're going to make one single change in your diet to affect your cardiovascular health, this is it. Doing this increases your high density lipid, which is the good cholesterol. It decreases the LDL. It decreases the production of that little cap that takes that particle, that ApoB, takes it inside the endothelium. It decreases the amount of insulin that you're secreting, and insulin is a very inflammatory hormone. So overall, your inflammation is decreased. If you didn't take anything away from this lecture tonight, take this 1 point back, okay? Lean animal protein. Heather happens to be vegetarian. I'm meatitarian. So, but really think about where your meat's coming from. We really try hard to get the wild-caught fish, grass-fed beef. I mean, this is beef that's out in the pasture, or pastured animals tend to be have less saturated fat in their meat and higher levels of things like conjugated linoleic acid and omega-3 fatty acids. So wild-caught fish is kind of hard to find here in Kansas, although trout, lake trout, are very high in omega-3 fatty acids. High-fiber foods like oatmeal that's been unprocessed can be helpful. It reduces those sugar spikes and insulin and subsequent insulin spikes that come behind the sugar. Increasing your omega-3 fatty acid intake. So again, the cold water fish, things like sardines and salmon, the bluefin tuna, mackerel, I'm leaving a few out, herring, all of those are really, really high in omega-3. You're not going to get high omega-3 levels by eating cod, orange roughy, tilapia. Even though they're good sources of lean protein, they're not really going to increase your omega-3 fatty acid levels. All hydrogenated fat. So again, think about that partially hydrogenated. Partially hydrogenated equals trans and equals a really, really dangerous fat. So stay away from all of those. Increase the use of healthy oils. Again, olive oil is one that we really like. It's hard to find good olive oil. Kristen kind of pointed out the fact that a lot of olive oil is being cut with soybean oil, and that actually the government in Italy is really trying to crack down on this. They're importing Malaysian soybean oil into the harbors at night and sort of sneaking it into the olive oil factories. And it's not a good oil. It's just a cut above the biodiesel, I think, is what I remember reading. So the olive oil company in California?
It's called California Oil.
There you go.
Yeah,
California Oil. It is certified and it is just olive oil, olive from. So, and reducing alcohol intake. I think alcohol, we didn't really touch on it, but a glass of red wine for a man and a half glass of red wine for a female can be heart healthy. Most of us drink far more than that, so usually we have to focus on reducing that. And eggs, they're back on the menu. So don't take the yolk out of your eggs because that's where the choline is, and choline can actually help reduce the bad cholesterol. So the whole egg is, what your grandpa was doing, that was right. We all need to eat the whole egg. So supplements are the next thing that we kind of talk about, and supplements can be really helpful because they tend to have less side effects, and we don't have to worry as much about adverse effects. In fact, medication adverse events are now approaching the big 5 reasons why we die as Americans. So those drugs in the 50s we were hoping would cure everything, they're rapidly coming up the ladder in causes for death. So I think someone said it was the equivalent of a 747 crashing every month. That's how many people we lose to medication adverse events. Every day. Okay, every day. So imagine if it was, you turn on the news, oh, another 747 fell out of the sky. I would think that would raise an alarm in most of us. You know, we got to do something about this. So really approaching things through diet and lifestyle, we're hoping to reduce the amounts of medication that we use. So niacin is one of my favorites. You'll hear mixed reviews on niacin. I think that's probably because there's just still a lot of no-flush niacin in the market, and people hear that niacin's good. They don't know which niacin to get. I myself am taking niacin. I take 2 grams a day. Do not try to take 2 grams when you go home tonight. You will turn into a human light bulb. It does cause flushing. The blood vessels open up and you will feel every little capillary in your skin. In fact, I came in the office one day and I told my staff, I said, hey, I know what I have a staff of all females. So I know what a hot flash feels like. And I told them about taking the niacin, and Jill, my receptionist, says, well, did you sweat the bed out? I said, no. She said, well, you don't know what a hot flash is. But I do have more sympathy now for women and their hot flashes. So niacin, you want to titrate it slowly. You can take a baby aspirin at night while you're titrating if you want to reduce the amount of flushing that you get. Usually try to get up to about 2 grams. Omega-3 fatty acids, just like the olive oil, there's a lot of bad omega-3 fatty acids out there. The fish oil, a lot of it is rancid. I had a patient today who came in for a 6-month follow-up. He had been, 6 months ago I told him to get on fish oil. I recommended the brand. He went to Dillon's, bought the cheapest brand of fish oil he could find. His numbers actually look a lot worse. And I have a feeling that the fish oil was probably a rancid product. And so his inflammatory markers went up. His actual omega-3 fatty acid levels went down. So I'm not sure what's in his fish oil, but we look for IFOS certified fish oil. So that's International Friends of the Sea. It's a third-party independent certification that companies have to get. There's only a few companies that seek that certification. It guarantees that the product is high quality, that it's fresh. If you're looking for one at Whole Foods, the brand Nordic Naturals, some of their product line is IFOS certified. So look for that IFOS on the back of the label. Red rice yeast is actually how Lipitor, which is a statin, was discovered. It's an HMG-CoA reductase, which reduces the amount of cholesterol that the liver produces. So red rice yeast has been used for hundreds of years for cardiovascular health. I think Japan is where probably the largest consumption of that is. Plant sterols, again, getting them from plants. So lots of vegetables. You'll get a reduction in your cholesterol by doing that. And then fiber supplementation. There's a fiber that's pretty popular now, glucomannan. You can find it at a lot of health food stores, and it can, again, decrease the sugar spikes that you're getting, and can be really helpful for reducing the cholesterol. CoQ10, we measure CoQ10 levels. That's one of the enzymes that we look at. It's a cofactor in a lot of energy-dependent processes in the body. When you're on a statin like Lipitor, it consumes CoQ10, a lot of it, and that's one of the reasons that people feel the muscle pain or they feel fatigue, is that they're probably depleting their pools of CoQ10. I've found very few people who have normal levels of CoQ10 starting out. So if you're going to be on a statin, definitely take at least 200 milligrams of CoQ10 a day. So exercise. You don't need to be a marathon runner to get the benefit from cardiovascular exercise, but you do need to be doing something almost every day. So I tell my patients to exercise every day because I know they won't, and then that way they'll at least get in 5 and 6 times a week. 30 to 45 minutes is probably adequate. We're actually in our lifestyle program telling people to do a 7-minute specific exercise program that targets every muscle group in their body, and it's a pretty high intense workout, wouldn't you guys say? But we do that every single day, and the reason we chose 7 minutes for this program is that I don't think anybody can tell me, well, I didn't have 7 minutes yesterday, so that's why I didn't do my exercise. So hopefully everybody can comply with that. It does. I mean, the first time you do it, you're like, oh, this is not too bad, and then by the second, third, and fourth night, you find your muscles are really stressed. So a high intensity interval, and that's kind of what the 7-minute program is. And you can just Google it. It's 7-minute exercise. It's on a lot of websites. It's actually more effective than a high intensity, high volume training because we're sending a neurohumoral signal. So a neuron in the muscle is actually sending out a signal through the bloodstream saying, hey, we really need some transcription factors. We need growth factor. We need insulin-like growth factor. We need to change and get more lean body mass. Let's start mobilizing some of that fat from the storage tanks. So that's kind of the benefit of doing that. Mark Houston, who's one of my favorite authors when it comes to a lot of this stuff, he wrote the book, What Your Doctor Won't Tell You About Heart Disease. It's a great book to read. It's easy for anybody to read. He talks about the 2-to-1 ratio of resistance to cardio. So you definitely do want some resistance in there. And I would say with the 7-minute program, you're going to get an elevation in heart rate. You're going to feel that cardiac exercise. We also want to reduce stress. I mean, we all live a very high stress life, and that 40-year-old that I mentioned earlier who had a heart attack last week, he was living a really good life, but he was under a tremendous amount of stress. And I'm sure that figured into the reason for his heart attack. Questions?